So welcome back to our ECG workshop, probably the final session of presentation. But of course, the remaining sessions will be used for educating ourselves with the sample ECGs, which are already with you. Normal variations, first of all, some of the normal variations you need to understand. Look at this ECG. So this ECG, first of all, whenever you see an ECG, you concentrate on this part. What is that part? That is called the standardization. The standardization is usually 10 small squares is equal to 1 millivolt. That is the standardization. So we keep it that if this rectangle occupies 10 small squares or 2 big squares, which is equal to 1 millivolt. Suppose the waves are very tall, I cannot fit all the waves, the 12 leads in the same strip of paper. Then I reduce it to half standardization, so that every wave I see is half the normal of the original one. So that is called the half standardization. That is done whenever there is a severe ventricular hypertrophy and things like that, or when the runs of ventricular tachycardia, then you will not be able to fix it vertically on the paper. You reduce it to half and do the standardization as half standardization. Then it has to be marked in red. It is half standardization. Then if it is marked here, let us say half standardization. If this is 5 millimeters, then it means it is originally 10 millimeters because I have reduced the standardization. The other way around. Whenever the complexes are very small, as in case of myxedema, as in case of emphysema, or as in case of very thick chest wall, then we need to amplify the complexes to really see the wave patterns. Then we double the standardization. Instead of 10 millimeters, we take 20 millimeters as 1 millivolt, and that is called the double standardization. Normally, 10 millimeters is equal to 1 millivolt is the standard standardization. Okay, normal standardization. If you have standardization, when the waves are too tall or too deep in amplitude, and double standardization when the waves are very small in amplitude. Okay, that is one thing. Always remember, AVR is a lead which is for having negative deflections in the P wave, in the QRS, and in the T wave. First thing that you can notice immediately after looking at the ECG, just flash your eye on the AVR. If this is not there, you are in for trouble. You have to look very carefully about every other lead. So this is something like a direct pointer. Is the P wave inverted? Is the QRS down? Is the T wave down? Is the ST segments normal? In AVR, if that is confirmed, you are probably dealing with a normal ECG. But that doesn't solve the problem. It only tells if it is not that way, it is abnormal. But if it is that way, it cannot say it is normal ECG. It is more a sort of excluding the abnormals. You can look at it. Cannot say it is normal way. You can say that it is abnormal after looking at the entire ECG, but this is the normal pattern of QRS complex in AVR. The other thing is the R wave voltages from V1 to V4 slowly V6 they increase. This is called the R wave progression. You see 3 millimeters, 4 millimeters, 6, 7 millimeters, 12 millimeters, again 10 millimeters, in 8 millimeters, the R wave progression. This is because the left-sided voltage is much stronger because of the left ventricle. As the lead proceeds to the left side of the chest, you see a taller QRS or the Rs there. Whereas this is the right-sided lead, the current is to down, left, and anterior. Down, left, and down and left. That is why whenever you have a left-sided lead, you get a sort of a taller complex, and the right-sided leads register a negative complex. And T wave is usually inverted in V1. P wave is very well seen, and this is one area where P wave needs to be studied. P wave study in V1 and L2 are the two leads we study the P wave. T waves are inverted. So these are important things, and ST segment should be baseline. That is the fate line. And the other observation is RR intervals must be constant. Look at here. This and this, this and this. Next RR intervals. RR intervals are constant. A standard baseline of the ST segments and RR intervals constant. AV are all inverted. V1, the S wave is deeper, and there is a progression on the R wave. There is negative V1 wave. And the standardization is seen as 10 millimeters is equal to 1 millivolt. That is more or less you are looking at a normal ECG. Okay, let's go down. Standardization 10 mm or 2 big boxes is equal to 1 millivolt. Double and half standardizations I told you. Sinus rhythm, each P wave is followed by the QRS. RR intervals are constant. Always examine the P waves in lead 2 and V1. QRS positive in L1, L2, L3, AVF, and AVL negative in AVR. QRS less than 0.08. That's another important thing. Duration of the QRS is not wide. It is narrow QRS. QRS in V5, V6. Its duration is less than 0.04, and the Q, of course, the Q in those things. If at all there is a Q, it's not a pathological Q. R wave progression, I have told you. QT interval, that's another important thing that you should look for, is the QT interval, which should be half of the RR interval. Axis, all four leads are positive, L1, L2, L3, AVF, isoelectric ST segment, upright T waves, normal T inversion, of course, in AVR, V1 and maybe into V2 also. Okay, so what is the QT interval here? Let us say this is the Q wave beginning, this is a T wave. QT interval is one big square plus another half, 1, 2, 3, 4. 4 plus 10 plus 5, 9. 9 into 0.4, 0.36 is the QT interval. Anything half of the RR interval. QT interval is okay. We have to correct the QT interval to the corrected QT interval. That's called the QTC. I'll show you how to correct it also. Then the pediatric ECGs are slightly different from the adult ECGs. Pediatric ECGs, usually you see the T inversions are prolonged into V5, and the transition may be in V2 or V3 transition. In adults, transition is usually V3 or V4. In pediatrics, it is V2 or V3. Transition means the R and S being equal. That is called the transition zone. And normally in adults, we don't see T inversions up to here. T inversion stop short here. And this much R wave also is not seen in the adult. So a pediatric or ECG, the R wave in V1 is comparatively positive than the adult ECG. The T inversions persist up to V3, and also the transition is around V1 to V2, and the heart rate is usually higher compared to the adults. So what is the heart rate here? 300, 150, 100, it's more than 100. So a pediatric ECG, there is tachycardia. Of course, always look for the standardization, and this is 10 millimeters. As you can see here, 2 big boxes is equal to 10 millimeters. Always we have to look for the standardization. Okay, now this is the ECG of a 6-year-old child. Heart rate is 100, normal for that age. S waves in V1 plus R wave is more than 35. So SV1 and RV5, which is 1, 2, 3, nearing 4, 20, 20 plus 10, 15, maybe 35. If that is the case in adult, it is LVH. But here, it is not LVH. This is not LVH. It is normal in children. T inversions up to V3. These are called the juvenile Ts. Baseline disturbances in V5, V6. You can see the baselines are undulating here. Why? Child is wriggling and then moving. And that's another indication that adults usually they lie down quiet. Children, when you want to take ECG, they won't give the cooperation, and some amount of baseline disturbance is expected. So I'm showing you another regular ECG. This is we have, as per our criteria, the AVR all are negative. V1T is negative, V2 onwards not negative. R wave progression is very good, and then the rate is 300, 150, 100, 75, or even less than 75, 70, and all are positive, normal axis, and there is baseline of the ST segments are normal. Everything is correct. But only thing that is missing in this ECG is the standardization. Without the standardization, you should never present the ECG. It is implied here that the standardization is normal. Otherwise, they would have mentioned it is half standardization or full standard. You have to write with red pen. It is half standardization or full standardization on the ECG, on the double standardization. If it is full, you don't have to. If it is double or half, we have to indicate. Okay. Normality upright in all these leads except in V1 and AVR. V1 and AVR are the two leads where T is normally down. L3 it may be by this way or that way, but other leads the QRS is up, T waves are also up. Now, this is called the juvenile pattern of the ECG. One complexes only I have shown here. So L1, L2, L3, AVR of course down, AVL, EAVF, V1, V2, V3. Up to V3, you see the T inversions. And there will be some amount of R wave starting there, even in the V1 also. So there is a T inversion till V3. And generally, the V6 S wave and R wave and V1 S wave together, normally if it is more than 35, it is left ventricular hypertrophy. But that criteria in children and juvenile ECGs doesn't hold good. You have to use other criteria. So Estes point criteria are there. So Cornell's criteria are there. The different criteria have to be used for pediatric and juvenile ECGs. 1, 2, 3, 4, 20, 22 plus another 10, 32. Sometimes it is more than 35. Resting ECG cannot exclude disease. Understand? If the resting ECG is abnormal, it can predict disease. It is a specific tool. But if it is normal, it cannot exclude disease. It is not a sensitive tool. Ischemia may be covered depending on the supply-demand equation. Suppose the person never moves his feet and never exercises, he may never experience angina, he may never throw any ECG changes. But once he walks, at least a few steps, then the demand is shifted more and then in relation to supply, and the changes come out. That is where we do a treadmill test. That is why to uncover the covert ischemia, make it overt, we do a treadmill test. Changes of myocardial infarction take a little time to develop. The infarct is starting now, at least half an hour, 1 hour, the changes will take time for the ECG to show. Mild ventricular hypertrophy is not detectable by ECG. Means what? For ventricular hypertrophy, ECG is not the best tool in hand. Then what is the best tool in hand? Echocardiography. Every hypertensive patient, every diabetic patient, everybody who is over 55 must get an echocardiogram for the assessment of left ventricular hypertrophy and left ventricular systolic function, and also the diastolic dysfunction. Of course, look at the valves also, and any valve motion abnormalities. 4 things are important. Is there LVH? Is there any valve motion abnormality? Number three, are there any valvular changes related to valves? And of course, is there any systolic dysfunction and diastolic dysfunction, the ejection fraction and the diastolic dysfunction? These are the four fundamental questions in the echo. LVH, systolic and diastolic dysfunction, wall motion abnormalities, and valvular abnormality. Some of the ECG abnormalities are non-specific, so we cannot swear non-specific T inversions, non-specific changes in the ECG will be there. Single ECG cannot be prognostic, it cannot give you prognosis. Serial ECGs, of course, will tell you whether the infarct is increasing, whether the patient is improving or regressing. ECG changes not always correlate with the angio results. How much we have understood, there is a limitation for the ECG to predict the culprit vessel. It can more or less say, but not exactly pinpoint, because the coronary circulation itself is not the same in all the individuals. There is a left LCX dominance, there is an RCA dominance, there is collateral circulation in some, there is no collateral circulation, some are age dependent, and whatever we are looking in the ECG is only an electrical change. It's an electrical changes are seen here, whereas the actual plumbing problem, the tube's obstruction problem, is a dynamic thing. It is not static. Sometimes there may be occlusion, dynamic occlusion. Sometimes there may be permanent occlusion. Sometimes there may be incomplete occlusion. All those are brought out by angiocardiography. Paroxysmal events will be missed in a single ECG. What is paroxysmal? Comes and goes. Something, a paroxysmal atrial tachycardia, ECG is normal in between the attacks. When the patient has the paroxysmal attack, if you record the ECG, you can pick it up. Then how do I overcome that? Paroxysmal attacks can be obtained by doing a Holter. Holter picks up for 24 or 48 hours. What if it is occurring once in 3 weeks or once in 4 weeks? I can't pick up by a Holter. Then what is called the intracardiac lead recording, ILR, intracardiac ILR and intracardiac lead recordings. You place the lead and leave it, and a small thing is tied into the chest or fixed to the chest there, and it will be there. And sometimes implantable recorders are there. Put it under the skin, and over a period of time, what happens? You can study that implantable recorders, intracardiac lead recorders. These are the other than Holter. Okay. Normal variations may have slight left axis, may have high voltages, stimulating LVH, mild slurring of the QRS, maybe just around 0.09, J point depression, early repolarization, T inversions up to V4, juvenile pattern. Similarly, in women also, chest leads, T inversion can be seen up to V4. This is another point. If it is a woman ECG and up to T3, V3, V4, you can expect that this one. Voltages in obese women and men are lower. Non-cardiac causes of ECG also are there. Now here, one more thing. So if the patient is obese and you make him lie down flat for recording the ECG, the abdominal obesity pushes the diaphragm up, and then that will be shifting the heart sort of horizontal. Heart, instead of being vertical in the chest, it is more spread out horizontally. That results in changes in the L3 and AVF. So what you have to do, you have to record what is called deep inspiration L3 AVF. Deep inspiration recording will push the diaphragm down. Ask the patient to take a deep inspiration and then hold the breath in deep inspiration. When the diaphragm is down, then you take a record, and if that shows T waves upright, even if the T waves are inverted when he is laying flat, if deep inspiration T waves are upright, then that excludes any organic change. Now, early repolarization. Early repolarization means this is called the J point. This point is called the junction point between the S wave and the next T wave. QRS wave, ST segment, and the ST segment is pulled up. You can see here, ST segment is pulled up. And this is not sort of ST segment elevation. The ST segment elevation means it must be horizontal, or it must be downward, or it must be coving. In the absence of that, if it is concave like that, it is only a early repolarization, also called the J point elevation. So this is not abnormal. So beware of this early repolarization. And how do I interpret this? There will be no symptoms related to the ST elevation. T waves are absolutely normal, and along with the ST and T merge and they're pushed up. That is how we record here. Now, suppose patient is emphysematous. Emphysema is distension of the lungs due to alveolar destruction and then filling with emphysematous spaces, bullae and all that. And there is hyperinflation of the chest, hyperinflation of the lungs. That leads to low voltage complexes. V1, V2, V3, AVR, AVL, AVL. L1, L2, L3, AVR, AVL, V1, V2, V3. So all the complexes are. So if you look at the V5-1 and V2, V3, V4, V5, V6 on the right side, then you can see still some more activity on the right side also, because the heart is more or less vertical instead of being to the left. In emphysema, the heart is more or less vertical. So you record right-sided leads also in a case of emphysema. There is what is called the pseudo-normalization. This also you have to understand. What is pseudo-normalization? This is the baseline. Okay. So baseline ECG, ST segments are here. When the patient has chest pain, baseline, the ST segments are slightly on the lower side. When he has chest pain, these will get up a little up from here and appear as though they are on the baseline. Then once the chest pain is resolved, you can again see the ST segments back to their original position. In some ECGs, the baseline ECG may be showing without chest pain, there may be some slight 1 to 2 millimeters depression. But in case of chest pain, because of the slight elevation there, this particular depression is no more seen and again comes back. This is not normal, though it appears normal. This is not normal. This is what is called the pseudo-normalization. What does it tell? It tells only impending ischemia. Early repolarization already we have seen. So this is an early repolarization ECG. So this thing, same thing. The J point is pulled up, and along with the ST segment, the T wave also is pulled up. ECG has normal features. ST junction J point is elevated. T waves may be tall, inverted in lead 3. T wave inversion may be there, sorry. T wave inversion in lead 3, it is of course not inverted. They may be inverted in lead 3 also. And the ST segment initial position is concave, does not signify ischemia. Now, non-cardiac conditions changing the ECG is also important. So the Q wave is this one, and this is the end of T wave. From the beginning of the Q wave to the end of the T wave is called the QT interval. Okay, QT interval should be less than 50% of the RR interval. Let us look at that this ECG. So what is the beginning of the Q wave? We don't have a Q wave, but we have a beginning here. Or we can as well look at the V5, where this is the beginning of the QRS complex and this is the end of the T wave. How many boxes are there? 1, 2, 2 full boxes plus a little 1 box, small box there, and 3 small boxes here. 3 plus 1, 4. 4 plus 5 plus 5, 10 plus 4, 14. 14 into 0.4, 56. 15 into 14 into 5, 52, 56. Normal is 0.4. So there is a prolonged QT interval. Here also you can see there is 2, 2.5, and another half, nearing 3 boxes. 3 boxes is 0.6 or 0.56. So 0.4 is the upper normal limit. There is a QT prolongation. Okay, is it more than the half of the RR interval? What is the RR interval? 1, 2, 3, 4.5 boxes, or 4 boxes and 2. 4 boxes is 0.8, and then 4 boxes is 20, 20 plus 2. 22 is the small boxes is there. 4 into 5, 20 small boxes and 22. Here it is the QT interval is, much is the QT? QT interval is 1, 2, more than 2, nearing 3 boxes, near more than half of the RR interval. Okay, so this is what is called the prolonged QT interval. And you know the QT interval is dependent on the rate, so you have to correct for the rate. Important, how to correct for the rate? That we will see here. So QTC is called, QTC interval should be worked out. Corrected QTC is equal to QT interval divided by square root of the RR interval. Now I'll give you a small sum. The QT interval is 0.5. RR interval is 0.9. Okay. What is the corrected QT interval? Work it out. QT interval is 0.5. RR interval is 0.9. Square root of 0.9, you get some number. So QT interval divided by that number will be the corrected QT interval. So you can work out like that. Or there is a metcalc is there. If you tell the heart rate and tell the QT interval, it will give you the correct QT interval. When is it prolonged? Sleep, hypocalcemia, acute myocarditis, AMI, acute myocardial infarction, quinidine, procainamide, tricyclic antidepressants, cerebral stroke, hypertrophic obstructive cardiomyopathy. These are some of the conditions where QTC is prolonged and it is shortened in hypercalcemia, hyperthermia, vagal stimulation, and digitalis affect. It could be a short notes also. Comment on the QT interval. You have to put the ECG diagram, identify what is QT interval, say what is corrected QT interval, what is the normal relationship to RR interval, when it is prolonged, when it is shortened, and what are the drugs which should be avoided when there is QT interval prolongation. All your prokinetic drugs are dangerous when there is a QT interval prolongation. What are prokinetics? Your domperidone, all your so many prides you'll be using, no? So for the vomiting and kinetic motility, levosulfide, these are all the drugs which can prolong the QT interval, which can affect the QT interval. It's to be very careful. Likewise, hydroxychloroquine is also a dangerous drug when the QT interval is prolonged. So we have to be aware of the drugs again which cause the QT interval. So this is called the electrical alternance. What is phenomenon of electrical alternance? That means one beat is very low, or other beat is stronger. One beat is weaker, one beat is stronger. Okay, you can see here. This is the weaker beat, this is the stronger, weaker, stronger. So this is a weak, stronger, weaker, stronger, weaker. Like that, weaker beat, stronger beat. This is because the contractility of the ventricles is not uniform and electrical activity is weak and strong, weak and strong. But this is not ventricular in origin. The impulse is originating from the atria. That is why we are seeing a normal relationship of P waves and QRS complexes and narrow QRS complexes. This is a forerunner of impending ischemia. Electrical alternance, if you see, he is a candidate for ischemia. Bulb chodandi, if it is flickering, not properly burning. So that means it is burning brightly and again bright, dim, bright, dim, bright, dim. That's an indication the bulb is going to fuse. Similar is the case here. Note the typical ECG changes. Every alternate QRS complex has a small and large amplitude, but all are the sinus origin. Because the QRS is narrow and the PQRS orientation is maintained. Heart rate is 110. There are P waves preceding all QRS. This is a feature of pericardial effusion with cardiac tamponade. So electrical alternance indicates one is an impending ischemia, the other is effusion with cardiac tamponade. Ventricular bigeminy. Ventricular bigeminy means there is an atrial, sternodal beat followed by a ventricular beat. A ventricular beat and supraventricular beat. So this is the supraventricular contraction from the SCA node. This is the ventricular contraction. Okay, so this is the narrow QRS is the one coming above the ventricles from the atria, from the SCA node. This is from the Bizarre complex. Funny looking beat, FLB, is the ventricular one. So if this is alternating, one after the other, and if you take a longer strip, you see normal beat, ventricular beat, normal beat, ventricular beat, normal beat, ventricular beat. Such a thing is called the ventricular bigeminy, ventricular trigeminy, ventricular quadrigeminy, depending on whether it is 1:1 or 1:2 or 1:3, the ventricular complexes in relation to the normal sinus nodal complex. So ventricular bigeminy is again an indication of impending ischemia. Normal beat, that is the ventricular premature beat. So you can see the ventricular premature beat and normal beat like. Each normal sinus originated ventricular complex with narrow QRS is followed by a premature beat with wide and bizarre looking, funny looking ventricular complexes. Similarly, trigeminy and quadrigeminy, these ectopics signify heart failure. In this ECG, there are features of inferior myocardial infarction. Where are they? Yeah, you can see here. So you can look here, there is some amount of Q waves there and ST elevation also is there. You can see the ST elevation in the inferior leads, L3 AVF. So that is suggested by these two suggest that there is inferior myocardial infarction. So impending ischemia and heart failure here, there impending cardiac tamponade and pericardial effusion and ischemia there. Then myxedema. Myxedema is a condition where the metabolic rate is lower. Because of the lower thyroxine levels in the system, there is metabolism is slowed down, there is bradycardia, and also voltages are lower. If you see an ECG with bradycardia and low voltages, you have to think of ischemia. Only low voltages, think of emphysema, pleural effusion on the left side, or pericardial effusion. Simple low voltage. Low voltage with bradycardia, myxedema. What is the heart rate here? This is a P complex 300, 150, 100, 75, 60, 50. So maybe less than 60, a little more than 50. So maybe around 56 or something. It is so it's worked out here some around 50. 300, 150, 100, 75, 60, 50. Yeah, looking at these things, it looks 50. So around 50 beats is the heart rate. Rhythm is regular, and before each QRS there is a P wave, and that P wave is identical as you can see here. The P waves are not different, so they are monomorphic only. That is, they are resonative to the sinus node. The PR is not changing. PR interval is within that period. QRS is less than 0.12, which means there is no ventricular origin. Everything is from the atrial. Such an ECG, low voltages with bradycardia, one should think of myxedema. We have diagnosed several people with hypothyroidism looking at the ECG alone. The ECG shows bradycardia low. Look for thyroid. Thyroxine is TSH is very low. So bradycardia, heart rate 50-55, low voltages of all complexes less than 5 millimeters. When do you say low voltages? That is important. It should be less than 5 in limb leads and less than 8 in the chest leads. So if the deflection size amplitude is less than 5 in limb leads and less than 8 millimeters in chest leads, it qualifies for low voltage. What are the DDF low voltage complexes? Pericardial effusion, constrictive pericarditis, severe emphysema, pneumothorax, or left-sided pleural effusion. In all these conditions, usually the heart rate is either normal or elevated and no bradycardia. Only in myxedema, you have low voltages and bradycardia. Subarachnoid hemorrhage. Okay, this is an exercise for you. Find out and tell me why there are ECG changes in subarachnoid hemorrhage. So the why of it I am not telling you, but what of it I am telling. In subarachnoid hemorrhage, there will be very symmetric, very sort of deep T inversions, you see. This is global. Almost every lead shows, except the AVR, which will be upright and V1. V1 and AVR, normally they are down and they become up. V1 and AVR, we always expect the T to be down and they will be showing a upright T, and all the other leads will show a global uniformly deep T inversion, which is a classical feature of subarachnoid hemorrhage. Why it occurs, you find out and tell me next class or write a message. Striking ECG changes of non-cardiac origin, incredible deep and symmetric T inversions in young persons with massive subarachnoid hemorrhage, has no cardiac disease. This is called the cerebral T. Presumably due to autonomic dysfunction, has headache and has very high blood pressure, lumbar puncture, clinches the diagnosis. You tap blood-stained fluid, and that is subarachnoid hemorrhage. And before doing lumbar puncture, ascertain that there is no papilledema. Otherwise, lumbar puncture is a risky procedure, and you have to do a guarded LP, not letting the whole fluid jet out, like a fountain, but drop by drop, keep the stillet inside and allow drops to fall carefully. Hyperkalemia. Whenever there is potassium high, normal being up to 5.5 milliequivalents, anything more than 6 or above, we call it as hyperkalemia. And at that point, you see tall T waves, tall peak T waves, and again they will be global. They will be all leads, and of course, AVR will be showing deep T waves, and V1 may be this way or that way. And this sort of changes are called tall T's of hyperkalemia. No other ischemic features are there. And then axis also is normal. But thing is here, T wave is called the 10th house of potassium. T is the 10th of potassium. There is more potassium, there will be taller T waves. If there is no potassium or low potassium, then there will be depressed inverted T waves. So T is the 10th house of potassium. Hyperkalemia, tall T waves. Hypokalemia, inverted T waves. So 58-year-old man with chronic renal failure, serum creatinine was, serum potassium was 7.6, normal up to 4.5 or whatever it is. Hyperkalemia ECG, smaller absent P waves. Okay. Yeah. P waves are not discernible very much. And then atrial fibrillation, not in this ECG, it might have an atrial fibrillation. QRS is usually white, that we can appreciate here. QRS is white, and then the shortened or absent ST segment, wide and tall tented T waves. Wide and tall and tented T waves. ST segment is almost absent or shortened, it is pulled into the T. So T wave is the 10th house of potassium. Hypokalemia. So the T waves are inverted and U waves appear. This is a U wave. appearance of the U wave after the T wave. U waves are positive waves occurring after the T waves. Normally not seen. In hypokalemia, you see them. And heart rate is usually at the little lower side. Hypokalemia, 22-year-old lady with prolonged vomiting. Because of vomiting, she lost a lot of fluid, vomitous fluid, and there is hypokalemia. Serum potassium was 1.8, normal of 2. Of course, hypokalemia changes are smaller absent T or inverted T, prominent U waves, see the pointer there. That is the U wave. T wave is the 10th house of potassium. More K, tall T, less K, flat or inverted T. Wandering baseline. So if the ECG is recorded like this, we cannot interpret any ST segment elevation or ST segment depression. This is like a mala, going down and coming up. This is there is a drift in the baseline. Undulating baseline with a waveform is present, and such an ECG is very uninterpretable. Why is it due to? It is due to the improper contact of the leads. What you have to ensure is the lead should be properly cleaned. The metal surfaces should not have any crusted old jelly and all that. Frequently, after every ECG, the metal parts of it, the lead should be properly cleaned. And also, if possible, you can wash the lead plates with detergent or some tamarind-like thing. They are all brass ones, so become very bright, and no crustaceans will be there. And good amount of contact jelly should be used. Okay, so then you can avoid the wandering baseline. So if the wandering baseline is there, it interferes with the interpretation of the ECG. Now, non-cooperative child, excessive movements, movement disorders, not properly earthed machine, additional wet ground earth may also have. Lead contact and earthing are two basic things. Earthing is not done, the pacemaker will be wandering. Another thing is, so if you have multiple electrical appliances to the same outlet, that also can lead to a sort of disturbed baseline or a wandering baseline. So excessive movements of the patient, movement disorders of the CNS in adults also, proper earthing and also cleaning of the leads, and then additional wet ground on the earth. What we do is, we take a little cotton and then dip it in water. It is wet cotton with almost dripping a few drops of water. And there is a clip, metal clip. We attach the metal clip to the cotton, and the wire of the metal clip is connected to, there is an earthing inlet into the ECG machine. So into that you correct. So this is an additional ground earthing you do with a wet cotton. There is a metal clip, and then the input is the ECG. Machine will have a earthing input. Either you can use wet cotton and leave it on the floor, or you can clip it onto a tap. And nearby, if there is a running tap nearby, metal tap, not plastic tap, to that you can clip it and allow the tap to flow slowly. Small drops of water coming. And there is water flowing, and the metal is there, and that earths the whole system. So this has to be followed whenever we find a wandering baseline. Another thing is, always ECG recording outlet, it should have a separate board and no other equipment to be connected to the same electric board. So this is muscle tremor. So maybe due to anxiety or tension, or due to cold weather, shivering, there could be the fever. Somebody is about to get fever, chills and rigors, and muscle tremor, somatic muscle tremor, you can say. We cannot interpret anything if you get an ECG like this. Limb movements, baseline fluctuations, tense muscles, hairy chest interferes with proper contact, better to shave the area if needed, reassurance, starting recording a few minutes after the leads are placed, that is to reduce the muscle tension. So you place the leads and keep talking to the patients for 1 or 2, for 30 seconds or 1 minute. Then they become relaxed and muscle tension is not there. Then you start recording the ECG. So this is AC interference. So when the same outlet has got AC power as well as the ECG machine power, this is how it got recorded. and exactly this has got 60 cycles per minute. That is the frequency of the current there. And then once we disconnected, put off the AC and disconnected the AC plug, you can see normal ECG. Okay, this is exactly something like very common when we have a multiple electrical gadgets connected onto the same circuit. So an electrical gadget operating in the same electrical line or circuit may interfere, like mixie, motor, musical tube lights, grinders, even the geysers. Proper earthing is essential. Dedicated direct line for the ECG power point is important, or disconnect the ECG from the main. If there is a battery recording, use the battery mode, and then no problem. No other artifacts will come. The artifacts are quite misleading sometimes. So this is the end of the beginning. What is this? This is the end of the beginning. Means that you should start working from now on, looking at every ECG that you come across, and then start analyzing in the way that is told. Now, how do I write a report? That could be another 5 minutes time we can take. Number one, rate, rhythm. Sinus rhythm is exemplified by P waves, PR segment, QRS complex, ST segment, T waves in that order. And RR intervals are constant. QRS is narrow. These three have to be fulfilled to say a sinus rhythm. PQR-ST relation maintained. ST segments and PR segments are baseline. No RR intervals are constant. QRS is less than 0.08. Then it is a sinus rhythm. Rate, rhythm, axis. All four leads, L2, L1, L2, L3, AVF up, right meet, left lead. And you can point also depending on which is the highest deflection. That will be the direction of the axis. Or if there is a sort of a lead where the upper and lower strokes, are zero and exactly perpendicular to that is the axis. And you can also plot, as I told you, depending on each lead, which is the positive one, and place it on the 12 lead ECG axis diagram, and you can get an exact axis estimation. Usually, P axis is same as the QRS axis. Okay. So rate, rhythm, sinus rhythm. If it is not sinus rhythm, if it is arrhythmia, then what you have to say, is it atrial? Is it junctional? Is it ventricular? Is it tachy? Is it brady? Is it commensurate with that area? The rate commensurate with that area. Is the conduction antigrade or is the conduction retrograde? Is it irregularly irregular? Is it regular? Irregularly irregular? Regularly irregular? Bizarre, and then no pattern. That is to comment on, is it supraventricular or is it junctional? Is it junctional or ventricular? This is depending on narrow QRS or wide QRS. Is it paroxysmal? Is it continuous? Okay. So these are the questions we have to answer. Then after that, what we have? Rate, rhythm, axis, then the QRS complexes. What is the duration of QRS complex? Shape of the QRS complexes. And then the QT interval. Normal being 0.4 and less than 50% of the RR interval. Prolonged QT interval is important to note and conditions. Then the PR interval. The PR interval, is it normal? Is it progressively lengthening? Is it prolonged? Is it progressively lengthening until one beat is dropped? Or the PR interval is constant, but there are certain dropped beats? Type 1, type 2. Then in the type 2, there again Mobij and the Wenckebach, and then complete heart block, type 3. Then other conduction defects like LBB, RBB, anterior fascicle, posterior fascicle, trifascicular type of blocks. Then you move on to hypertrophies. atrial hypertrophy, right atrial hypertrophy, left atrial hypertrophy. Both should be looked at in lead 1 and lead 2 and V1. And biatrial hypertrophy, both are enlarged. Left ventricular hypertrophy, right ventricular hypertrophy. Voltage criteria for LVH and right ventricular hypertrophy, R by S in V1 is more than 1. If R by S is more than 1, is it like it may be right ventricular hypertrophy, maybe posterior myocardial infarction, maybe right bundle branch block, maybe clockwise rotation, maybe anti-clockwise rotation of the heart. So this is the story about the hypertrophy. So we have completed rate, rhythm, axis, QR interval, QRS complexes, QT interval, ST segment, and then the QT interval we have done, and also we have looked at the PR interval and heart blocks and conduction defect. Then we go on to the ST segment. Is the ST segment isoelectric? Is it depressed? Is it elevated? Is it unstable angina? Is it NSTMI? Is it STMI? If it is so, which wall is affected? Anterior, anterolateral, posterior, anteroposterior, inferior, posterior inferior, various combinations. Which culprit vessel is probably involved? And how old is the infarct? Is it early? Is it late change? Is it treated? Is it untreated? All those things will be there under the ST segment and T inversions. T inversions suggest ischemia, ST segment suggests injury, Q waves suggest infarction. If there are Q waves, they are pathological cues or physiological cues. How do you distinguish? 3 millimeters or more in depth, and then more than 0.04 centimeter, 0.04 seconds is the width. And usually it is compared to the next R wave, must be at least more than 1/3 of the R wave. That's about the Q waves, ST segments and T waves. Then you have got the miscellaneous changes, like what we have seen, electrolyte changes, non-cardiac conditions, so juvenile or adult changes, ladies, and then flat diaphragm and push diaphragm due to obesity, L3 the L3 AVF, deep inspiration, there is an arrhythmia, long strip, all these have to be taken. So that way, ultimately you have to make a conclusion. That is what you have to say. This ECG shows evidence of such and such a condition. Very clear cut. If it is ischemia or infarction, you have to say which area, probably which vessel, and then how old it is. If it is arrhythmia, you have to say supraventricular or ventricular, and then classify it properly. If there is hypertrophy, clearly say right ventricular, left ventricular, biventricular. This axis deviation, comment on that, left, right, or. So this is how you complete the report.